I'd like to welcome our special guest, Dr. Alex Volpi, to the podcast tonight. Dr. Volpi is a graduate. Correct me if I'm wrong with any of this, Dr. Volpi. You're a graduate of Wake
Sure.
Forest, correct?
That is correct.
And you did your medical school at Drexel University in Philly,
Yep.
and then you did your orthopedic surgery residency at one of the most prestigious institutes in all of the world.
That is right. That is right. The Hill.
The Lenox Hill Hospital. Yes.
Exactly.
Now that Ohio State has lost in the championship before the championship game, do we still have to say the Ohio State University, or can we just say Ohio State? I don't know.
I think they've
That's
lost
sidebar.
that,
Sorry. Sorry. And then I read when I was preparing for this that you went out to the Kerlan-Jobe clinic and did was Dr. Jobe still there, or his son, when you were out there, or no?
No, it's kind of it was some of the old guard is still very involved in teaching, but there's a lot of, kind of the young guys too. So
I'm sure Neil was there, right?
of course. Oh yeah,
Yeah.
he's a huge part of it. So,
Yeah,
definitely a great experience there.
Absolutely. Good. All right. So, being that you did a fellowship at the Kerlan-Jobe clinic, you are probably well versed in shoulder and elbow. So we chose an article that deals with posterior shoulder instability tonight. Okay. It was an article that reviews 3 different cases, and
Right.
it's something that we don't see a ton of on the playing field, and maybe you see it in the hospital and the clinic a lot, but certainly we don't get a lot of experience as sports medicine physical therapists or athlete trainers with posterior shoulder instability. Possibly the subtle stuff, that sort of that posterior impingement, internal impingement we see, but I wouldn't call that instability. That's sort of like a micro instability.
Exactly.
The instabilities we see, Doc, are probably anterior. Would that be the most common one in your practice? And
That's
then
definitely the most common one. Yeah. I mean, that people are familiar with, about that the shoulder popped out. That's the most common, that's the most common one. So,
right. And then you have inferior and multi-directional. I can't say that in the sports medicine population, I've seen a lot of inferior instability where it's popping out inferiorly. Maybe it's just a component of multi-directional instability, possibly. But
yeah, usually with like ligamentous laxity or even some other types of higher energy trauma. But the anterior is the kind of the most common one we see in our, especially in the sports medicine practice that we do.
But you do occasionally see posterior shoulder glenohumeral instability, correct?
Definitely. I mean, more so the chronic micro trauma type where it's attritional over time, it's typically not one specific traumatic injury, although I have had one, like the cases in the article, I have had 1 or 2, but one that had to operate on where it was a true locked posterior dislocation that needed surgery and grafting. So it does happen, but that's one for the X amount, whatever hundreds of the anterior dislocation. So it is quite a rare thing to be seen, and it's more so, and with the sportsman in the athlete world, that's more of the chronic or the micro instability where it's not like it popped out and had to pop it back in, but it's that chronic pain. Sometimes it subluxates. They feel symptoms when they do their sport or their activity. So that's the more common type of presentation of posterior instability that we see.
Right.
I had a patient recently who had a seizure. And like a seizure.
Yeah, go.
And then my patient had a seizure and had a posterior dislocation. So that was interesting. I'd seen one like that before, but obviously not very common, but interesting.
It is very rare. The incidence, in fact, according to the literature, is only 5% of all shoulder instability cases in the literature are 5% are posterior or straight posterior shoulder dislocations or instability. Certainly the two that I remember in my 30 years of practice is a wrestler at Hofstra. He landed on his elbow with his shoulder flex, and it went out the back.
Mhm.
And then
Yep.
also an offensive tackle who also was getting bull rushed by somebody way bigger than him, and that went out the back. I just laid them down in the training room on the plinth and hung their arm just off the side of the plinth like I was taught, and they kind of self-reduced, but they need to be fixed later.
Right.
Let's get into acute versus chronic, that micro trauma, posterior shoulder instability. Can you go over, Doc, the mechanism of injury for that acute injury, that one that I talked about possibly, and then the micro traumas?
Yeah, so as both you just kind of mentioned some sample type cases. I mean, the mechanism, or at least the position of the arm and the type of force that needs to happen for the shoulder to dislocate posteriorly is just as you described as that wrestler with the arm in that flex adducted, internally rotated position. When that axial load against it forces the shoulder right at the back. And, usually similar to the concept of traumatic anterior instability, you would tear the labrum structure, you would tear the capsular ligamentous structures, and that would force the humeral head posteriorly. Now, in the setting of the seizure disorder, even it's a common, even back to med school, buzzword, your seizures and like an electric shock, like being electrocuted, cause a posterior dislocation. And that usually is more so when it is actually locked. So when you can have a bony defect or the reverse Hill-Sachs lesion, where the Hill-Sachs lesion is an anterior instability where it kind of takes a chunk out of the humeral head and it gets stuck posteriorly. So that's the more severe acute type of mechanism with those buzzwords of seizure and electrocution kind of thing, where it can lead to a full posterior and then a lock dislocation as well.
There are anatomical factors which predispose somebody to a posterior dislocation, doctor?
Yeah, some anatomical factors, also quite rare things like glenoid dysplasia or retroversion. Those can sometimes be caused by brachial plexus injuries at birth or type kind of long-standing nerve injuries in a pediatric patient leading to glenoid dysplasia. When they become an adult, the socket, just how it's shaped, the ball can slip out the back easier. That's on the bony side. On the soft tissue side, if there is ligamentous laxity, we use the term patulous capsule, where the ligaments are just overly stretched, kind of in the MDI type picture, where you catch the right force, it doesn't have to be that traumatic. The shoulder can be pushed out posteriorly. So types of that. I mean, there's other subtle trauma things, like if there's injury to the subscap or lesser tuberosity fractures, it could preclude you to posterior instability. But those are the kind of the main anatomical variants that could predispose someone to posterior instability.
When a person thinks that, hey, you know what, my shoulder, I think, popped out the back, is it a different presentation than somebody who says, oh, I think I dislocated my shoulder and it popped out the front? Can you go just through a little bit of your experience with clinical presentation? Is it painful? Do they have weakness? Anything that would help us out as clinicians?
Yeah, I mean, it's definitely a different type of presentation than anterior. Anterior instability is the classic. My shoulder popped out on the field. It was either reduced there. I went to the hospital, had it popped in. It's a classic reduction type story. The posterior is definitely a little bit more different and subtle. Some people, again, with different, whether it's laxity, whether it's hypermobility, whether it is some sort of anatomical variant or just their build or their activity, sometimes they can feel like the shoulder's dislocating when it may not be, or vice versa. They may be saying, I'm doing normal type things. I'm doing bench. I'm a lineman. Every time I push off of, I'm doing my drill and I'm pushing off the defensive player, I feel my shoulder slipping out the back. So the story of the presentation is a little bit different and can be more nuanced. The more acute, severe types of that posterior lock dislocation, that's one that you always have to be hyper vigilant of, especially in the office setting with people coming in either from ERs that maybe they don't have ortho on site, or some urgent cares that don't have x-ray. These would be the people that say, I think my shoulder moved or slipped out the back or it popped out. and they cannot move their arm, meaning if it's
How about the
locked
how about the
posteriorly,
trauma? How about the trauma patient that you might have saw at Lenox Hill Hospital? Did you ever have one at
yeah,
Lenox Hill Hospital when you were on call and you're like, oh my God,
definitely. Oh yeah,
yeah?
of course, of
And
course. Oh yeah, yeah,
so I watched you as a resident put the anterior dislocations in where you would give a long axis distraction. You put either a
right.
sheet or a towel in their axilla. I saw you do that live, but
Yeah.
I never saw you do a posterior one. How do you put a posterior one back in?
Yeah, the posterior one, if it is truly locked, and that's why proper and good x-rays are very important, because if there's no bony, if there's no bony issue, meaning if it's just the ball is intact and there's no defect, there's no reverse Hill-Sachs, there's no glenoid fracture, then um, in theory you could, reduce a posterior dislocation. Now, again, sometimes just from where it sits, it can be quite difficult. Whereas the anterior, there's textbooks written about how to reduce it. There's a million different techniques and ways.
Hmm.
When you have that locked chunk out of the head and it's sitting on the glenoid, that's almost, I mean, sometimes you don't even want to try to reduce those because that
Right,
can
right,
cause more trauma. You start cranking on that and it doesn't move, you could cause a spiral fracture of the humerus. You could, cause a glenoid fracture. So you could actually do a lot more damage if you tried to pull and yank on a true locked posterior dislocation. But if it's the whole ball in the socket in place, then you can kind of recreate the deformity. Kind of doing a little kind of reversing uh, the forces that came upon it to
okay,
you reduce it by abducting it and extending it. But if it is locked and you can see that there's a big piece out of it, you don't want to go cranking on it too much and cause more damage. And then because that needs surgery anyway. So that needs an open
right.
reduction, really. So
I want to continue with. I didn't want to continue down the road of the trauma and the electrocution and the and the seizure patient. I wanted to continue down since this is the sports medicine research rundown.
yeah,
I wanted
right.
to continue down the path of the patient who comes to your office and complains of that subtle instability versus that frank dislocation. And that athlete, she might say, Doc, I feel my shoulder slipping out the back of my socket." What kind of testing do you do? What kind of special tests do you do? Can you run us through some of your imaging and
Yeah,
some of your special tests?
sure. So we definitely always start with the basic test as far as inspection to make sure there's no deformity, make sure that the scapula has good mobility and is moving in sync with the other scapula. Um, Making sure the range of motion is well preserved, that there isn't some subtle deficit that could even lead to something like that the shoulder is either subluxating and locking, but making sure that the range of motion is fine. The special testing for the posterior labrum and posterior instability really is taking those forces that cause the instability and recreating them, and sometimes causing a subluxation or even causing pain. So, the two main physical exam special maneuvers we do are the jerk test and the Kim test. So the jerk test is, really with the arm up at the side, abducted,
Mm-hmm.
and you are basically recreating an axial load posteriorly and inferiorly on the humeral head on the glenoid. And if there is subluxation, well, then that's a positive test. The Kim test is a very similar test with the arm in just a little bit more forward flexion. Same thing, an axial posterior load as you adduct the arm. If that reproduces pain, then that's a positive test. And when you have a combination of both, then your likelihood of having true posterior instability is quite high. So those tests can be quite helpful. I mean, not you don't always have these patients subluxating in the office. But usually with an axial load in that direction, there is some pain that can be reproduced. Um, and then, from there, if you're, have a high suspicion for posterior instability, then we, proceed with imaging, which we always start, with standard radiographs to assess for any bony morphology, to assess for, you know, definitely to make sure that there is a reduction of the joint and that the joint is well aligned, check for any glenoid defects, check for any reverse Hill-Sachs lesions on there. And then, the gold standard is still the MRI scan to look at the soft tissue structures, look at the labrum, look at the capsule to assess for acute traumatic tearing, assess for capsule laxity. So, some more of the chronic, micro trauma type things, but also sometimes acute soft tissue trauma, not the big, lock dislocation. So you can still have a full posterior labrum tear, and when that's the case, the posterior ligaments, the posterior inferior glenohumeral ligament, which is the main posterior stabilizer, is not taut. It's not doing its job as a static stabilizer. So that, could lead you to that would lead you to the diagnosis of posterior instability, and then you would talk about treatment, paths from there.
Right. Big in the physical therapy world is clinical ultrasounds. Do any of your clinicians at your practice use that, either a therapist or orthopedic surgeons? Do you find it useful in the shoulder at all, for that matter?
I'd say, I mean, I don't typically use it for diagnostic purposes. One of
Okay.
my partners, he's our primary care sports medicine physician, and he's
Mhm.
definitely, way more savvy with the ultrasound. I'd say it's
Right.
more useful for rotator cuff pathology. Um, if you have, someone that has a massive tear, I think it's easy to pick up, and maybe it saves them a trip to the MRI. But um,
Okay.
for this, for posterior labrum stuff, it can be quite subtle, where even the MRI may not pick it up fully. You need to do like an MRI with a dye injection with an arthrogram to pick up on those subtle findings. So I think in
Mhm.
ultrasound, it's probably not sensitive enough for this.
Right. CT scan have any role?
CT scan would be the best to assess the bony morphology. So if you have any concern for a reverse Hill-Sachs, if you have any concern for glenoid bone loss, then a CT would definitely be quite useful. If you did have a patient with significant glenoid retroversion or dysplasia on the X-rays, and then a CT scan would
That's what
also
we
be
look
helpful
for.
for that. Yeah.
Excellent. Thank you. Before we get into treatment, any Donis or Rob, any questions on anything right now?
Yeah. Yeah, it seems like it's people are really delayed in getting a diagnosis. Is it because it's like what's people don't look for it? You gotta go to a specialist who looks for like why is it so delayed? It seems like.
Yeah, maybe it's I think it's kind of presents as something, quite minor that when you bring it up to, let's say your, GP, or kind of, just, see someone at first, kind of make a generalized diagnosis, just say, oh, you maybe, have a strain, or, maybe you overdid it, do some PT or rest, or, just kind of modify things. And, when in the you know, but in actuality, they have structural damage, and maybe they didn't elicit, like the history didn't match up. And sometimes it's not always that textbook history of, oh, the lineman was, pushing the guy, and it was a posterior load on the, shoulder. I mean, it could be, like we saw in LA, a lot of baseball injuries or happen like this, guys diving for balls, diving to slide to home plate. You could have gymnastic injuries. You could have, swimmers even. I mean, so there's like things that don't always add up, and that's why this is a very nuanced type of pathology, and the diagnosis can be tough, and that's why it's different than the anterior, where anterior is kind of easy, where you say, "Oh, shoulder popped out." I'll tell you what your MRI is going to
Right.
show. Your MRI is going to show a Bankart, it's going to show a Hill-Sachs. I mean, it's like you can
Yeah.
predict, and I can tell you the report. Whereas with this, I mean, there could be bicep, issues. It could be slap, pathology. There could be cuff issues. So this can kind of, go into a gray area that things get a little, gets a little bit hazy as far as what's the actual problem until, you get an MRI scan, and then you see that they're, kind of to whatever extent there is of posterior pathology.
Yeah. Somebody recently who had gone to the doctor and they had limited external rotation. So oh, it's a frozen shoulder. Go to therapy.
Yeah.
One of those
Yeah.
things is like they didn't look into deeper. Hey, it's resisted. It must have that limited range of motion. It's therapy. It's frozen. I thought that was kind of an
Yep.
interesting way to look at things.
Yeah,
There's
that's why
there's a
X-rays
lot.
and special tests are very
Yeah.
important. Sorry, Tim, to
Yeah,
cut you off.
No, that's all right. There's a zillion things that can cause loss of range of motion.
sure. Agreed.
Yep.
Um, but that's where we come in as physical therapists. Dr. Volpe, do you give us a shot to try to provide some stability and restore function and function to that shoulder prior to going to surgery? You're taking that posterior shoulder instability athlete straight to the OR.
No, I mean, if the shoulder is inherently stable and, it's not, locked posteriorly, then PT is it's always the first line. Like I said, if you have some damage, and it depends on the degree of, damage or other, pathologies. I mean, if there's a labrum tear and everything else is shredded and there's loose bodies floating around the shoulder, I mean,
Yeah.
they may not, do so well. But if there, is a posterior labrum tear, but, the shoulder is inherently stable, if a static stabilizer is damaged, well, then we want to work on the dynamic stabilizers, the rotator cuff, to counteract that and to stabilize the shoulder, get some blood flow, sometimes even get a healing response to that labral tissue. And, sometimes, people with less demands, maybe they were just, goof around and they injured the shoulder and they're not going to stress that part of the shoulder anymore. They do great. But, we definitely want to see their response if they rehab it, do everything they can to strengthen it, but still have pain or instability episodes, then that would be the indication, to actually stabilize it.
So, okay, so how important is like somebody who has early recognition of bone loss? Like, I mean, you're trying to do stuff, but they don't have any. They lost,
Yeah.
labral. Does that kind of, if you wait too long, are we causing more problems going forward if we don't address it too early enough?
Yeah. I mean, not so much that it would be, didn't catch it early enough as far as the bone loss goes. I mean, if there's a significant amount, I mean, the shoulder is usually not very stable, so they would have more instability events, or even, going posteriorly, the shoulder could get stuck. If there is, some minor bone loss, so let's say that they've had some subluxation events or they've had some injuries, but they haven't had it stabilized, and there is some early, some minimal bone loss, that'll be something to monitor over time, because especially in, in anterior instability and bone loss, there's the concept of attritional loss, or just over time that glenoid bone, it starts to wear down and it becomes a to that critical uh, portion. When there's not enough socket left, that ball's just going to slip out no matter what. So, I think that's more of like over a longer period of time, if, of a bone loss happening. But I mean, I think if there is enough of, the socket there, and they have, enough, ability to strengthen the cuff and improve their symptoms, then I think, they can maintain the shoulder.
Thank you.
And I've never used any glenohumeral joint bracing for a posterior shoulder instability. Do you have any experience with that, Dr. Volpe? I have used it for
I mean,
I've used the Sully for the anterior instability to limited success actually. But what's your experience with posterior instability in any kind of brace at all?
yeah, I mean, like, as far as like a functional, like, playing brace, you mean?
Yeah, exactly.
Not really. I mean, right. The Sully brace is definitely, what I give my athletes for,
Right.
for their anterior instability, just to protect them and, to go out for it. But it's pretty tough to, you know, for the posterior stuff, because for the athletes, it's really kind of their kind of function, or what they're doing in their sport, that's causing it, right? Like the lineman
Right.
pushing, right? I mean,
Yeah.
he's not going to avoid pushing, or, so that's what's tough. Whereas the Sully is more designed where if you had a traumatic fall, or the shoulder got into that position, again, like not on purpose, would help prevent it. So the posterior, it's a bit tougher to functionally brace it.
Right. So take him to the OR. What are you going to do in the OR? Are you going to do a posterior labor repair, plication? How are you going to look at volume, capsular volume? What will you do, Dr. Volpe?
Yeah, so it really depends. I mean, it really depends, on the specific pathology. I mean, sometimes these posterior labrums, they're not just posterior labrums. Sometimes they go around the whole glenoid. Sometimes it's posterior goes all the way inferior and anterior. So you just stabilize the whole thing. Sometimes it goes superior and it goes into the slap region or the biceps anchor. So you have to address sometimes, biceps pathology. But um, typically for isolated posterior labral tears, we try just to um, repair the labrum and to restore the tension of that posterior inferior glenohumeral ligament. The capsular plication concept, would be for someone appropriate if they had excessive ligamentous laxity. So if you were concerned about that, like if they had other hypermobile joints, typically we get an MRI with a dye injection in the joint to really kind of blow up the capsule, see how big it gets. Sometimes it does, expand, and you really don't pick up if you hadn't done the arthrogram portion. So if there was significant capsular laxity, then you would plicate that. In a standard, kind of someone that didn't have hypermobility, then if you did that, you could severely decrease the range of motion, which you really want to stabilize the shoulder but maintain as much range of motion as possible. So that would be the soft tissue procedure. And then, like we kept mentioning the reverse Hill-Sachs, if there's a bony defect in the um in the anterior humeral head, then that usually has to be addressed because that's usually part of the articular portion. So that part's going to be articulating with the socket. So, if you just have a shark bite missing, well, that's just going to engage. So that usually has to be addressed with a bony procedure.
Now's a good time probably to go into the article because the article is an article from Birmingham, England, and it talks about three cases, and one of the
Hmm.
cases is exactly what you're describing. So this article we chose tonight is posterior shoulder instability, spectrum of presentation and treatment of outcomes in it in three cases. So the article discusses how uncommon this condition is. It states that 10% of all shoulder instability cases, I had said 5% earlier, 10% this article states is posterior instability. And the common, we didn't go over this, but it's the most common presentation isn't, people don't come in complaining of instability. Oh, my shoulder's popping out. They complain of pain. And the pain is probably
Right.
the pain is probably generated by the posterior rotator cuff getting pinched between the posterior glenoid and the posterior humeral head. That's usually the source of the pain. We talked about the mechanism of injury that they discussed in this article in paragraph 2, and they talk about also in this article how the non-operative management has limited success in the trauma cases, but maybe in the athletic cases they might be it might be more successful as long as it's not that really high level article. Then they proceed to go into case one, which is a psychotic schizophrenia patient who has it looked like a locked posterior dislocation there, and they talked also about this light bulb sign. Are you familiar with
Yeah.
that light bulb sign, Doctor Volpi? I've never heard of that. Not that I
Oh
should.
yeah. So the light bulb sign that's like one of those, when the ER calls ortho on call and they say, "Hey, we got this frozen shoulder down here. Can you look at it?" And you look at the
Right.
X-ray and you see the light bulb sign. That's the telltale sign of the locked posterior dislocation.
Oh, all right.
Um,
I learned
yeah,
something
so
tonight.
it's
Thank you.
yeah, yeah.
Mhm.
So that's like right. So if you see that, especially in the office, I mean, if you see that, then you basically have to rule it out, and you say, get a axillary or get a CAT scan ASAP because that could be out the back. And I mean, we do it all the time in the office because sometimes people come in, with not so great x-rays from urgent care or outside places. And, we say we have to get new x-rays because your x-ray, I mean, there could be a light bulb sign and then they say that they fell, right? So, oh, I
Right.
fell, my arm hurts, I can't move it. Their x-rays could be a light bulb sign. So that's the big red flag that you have to rule out a posterior lock dislocation.
Gotcha. And then and then case number two is a 37-year-old man who said he might have been having seizures for 10 years earlier, but was not started on any kind of anti-seizure medication. But he did have a motorcycle accident. And if you go to the article and look at case two, figure picture B, you can see that that is a massive, large reverse Hill-Sachs lesion, which needs to be
Yep.
addressed in the OR. Correct, doctor?
Definitely, definitely.
What do you do for them, and would you do the same thing that the surgeons in this article did for them?
Yeah, so I think this one was,
This is case two,
yeah. I'm just trying to
and
um okay, yeah, so they had right,
the modified
right.
McLaughlin procedure, which I had to look up. I had no clue what that was, but
Well,
I did look.
well, in case right, so I think and maybe the previous one. So all right, so the modified McLaughlin procedure is a procedure where where it's basically a transfer of the lesser tuberosity just into the defect. So it's
Right
just
into the
shifting
defect. Yes,
their own
yes, that's what
anatomy.
they. Yeah,
So, so I mean, I mean, it's a non-anatomical procedure because you're moving something where it shouldn't be and you're changing tension,
right.
to kind of fill in that defect with their own tissue. Um, you're kind of just, putting whatever size the lesser tuberosity is, into the defect. You're changing the subscap tension. So, there's definitely reports of stiffness and loss of internal rotation strength. So, but it's one way to fill the defect. I think in this other case, they used a allograft
Yes,
from a femoral head.
yes.
So that's along the lines of what I do, but I actually use a humeral head allograft,
Okay.
which you can get. Yeah, I mean, it's definitely more expensive and different, kind of schedule and timing based than the McLaughlin, where you just put the lesser tuberosity in the defect. But when you can get a humeral head allograft and basically cut we call it like a little lemon wedge. We cut it to the size of the defect, you measure it, cut it to the
Mm-hmm.
size, and you can fit it in very well and fix it with screws. So and you can restore the articular surface of the humeral head. So that's what I do. That's what I did with the one case I did for this, and looked like a brand new humeral head surface, and it healed great too. So that's, I think, more so the gold standard as far as uh, restoring the anatomy with a large reverse Hill-Sachs. I mean, there might be people that still,
No.
believe in the McLaughlin, the modified, but I think nowadays with technology and training,
Yeah.
people are doing these humeral head allografts and trying to make it basically reconstructing the humeral head.
Absolutely. And Dr. Dillick et al. Has shown good outcomes both 2 years and 5 years out with that what exactly what you described using that femoral head or humeral head allograft
Mhm.
to fill the defect. So that was good that we have those outcomes already on that stuff too.
Yeah. And then the one thing to add too, in the older patient with maybe some arthritis already, worst case scenario, you just replace it. Sometimes
Yeah.
that has to be done too, especially if they dislocated big, big, locked dislocation,
Hmm.
bad, bad rotator cuff. You could do a reverse replacement for it. So that's something else we have the technology for. So um, a lot of different options now.
Absolutely. Do you find yourself ever doing hemi arthroplasties in the shoulder, or is it usually a reverse or a total?
Yeah, no, yeah. I think Hemis are completely gone nowadays just because of the
Okay.
technology we have with anatomics. And for reverse, I mean, reverse, you could, there's so many indications now. I mean, Hemis are rarely done. I mean, Hemi would be like a bailout if, like everything kind of crumbled in the reverse. If there was no bone or so. I mean, it's kind of like a
Okay.
bailout procedure at this point, with pretty poor outcome.
Well,
So,
I'm old. We used to do them, so I've
oh
seen
yeah,
a few
no,
of
I
those
mean
in the
it.
day.
Oh yeah, no, but I mean, even when I started residency, we did a lot of
Yeah.
hemis, and that was coming up on 10 years ago now. So there was still
Dr.
hemis being
Mendoza
done
used
for
to do them with
fractures
you.
and yeah, so there was
Remember
still
Frank used to do
hemis
them with
and
you. Yep.
yeah, I mean even fractures, but then nowadays, I mean a hemi for a fracture, I mean,
No.
that's kind of not the gold standard, at this point. So for something like this, a traumatic bone loss, probably, bad cuff, for this it would, probably get a reverse. You'd probably do an anatomic if something like this didn't heal or they develop arthritis down the road, kind of
Okay.
like, unlike arthritis of instability, yeah, with a well-preserved cuff.
Have you heard of the McLaughlin procedure where they put the subscap tendon actually in the defect?
Yeah, I mean, I've
I've
heard of
never
it,
seen
never seen
that.
it done.
No, I've
I
never
mean,
have
I've
I.
never seen, but you can see, I mean, sometimes you see patients with with x-rays with kind of weird hardware in the front of the shoulder, and they said, oh yeah, I fell, I had a surgery, they stabilized it, and I think that's what they had. And but that was what they did,
Yeah.
kind of, quite some time ago. So I've never seen that done, but still the concept of filling a void, of
Mhm.
restoring, at least of taking away that defect. So yeah, never seen it done, and you just kind of heard about it in the literature.
Exactly where I found it in reviewing for this podcast. Um, uh, mm, oh, that's an anterior instability question. Can I ask you an anterior instability question
Sure,
out of my
sure.
curiosity? When you have something with anterior instability, you have you got a Hill-Sachs lesion. How do you
Mhm.
know whether to leave it alone or hey, you know what, this is big enough where I need to do something? How do you make that decision? Do you make it in the OR? Do you make it with a CAT scan prior, MRI prior? How do you do it, doctor?
Yeah, usually it's done with the MRI prior. Um, people, they have entire days of conferences just on this topic, Tim. You know that.
I've
They
I'm
guys talk
yes.
about this for hours.
I'm in the
About doing a
ASES. I know.
yeah,
I've sat
yeah.
in on that stuff.
Right. And so guys go back and forth their
Oh
thought. I
yeah.
mean, I've heard, and you kind of what we're getting at, is doing like a remplissage procedure, which, is really just filling in that, defect.
Hmm.
And, I would say, I mean, some people, say, oh, I've, treated tons of anterior instability. I've never done a remplissage and, it's been fine.
Right.
Um, I think nowadays with like our advanced imaging, the technology of anchors that we have, the concept of, the glenoid track, which is one of the
Yeah.
big shoulder buzzwords.
Yeah.
Um, I would say if you have an off-track lesion, so if you have a huge Hill-Sachs lesion, but the glenoid is still um, there, meaning that there's not significant glenoid bone loss, then that would be an indication for a remplissage. So at least you're filling in that defect and minimizing any further instability. Because in theory, if you have a larger off-track lesion and you just fix the labrum, well, they could still get into that position and it could still
Hmm.
dislocate. So I think if you have off-track but just on the humeral side, I would consider the remplissage. And also it's patient specific, if it's like an overhead athlete or something, you don't really want to do that because they can lose mobility and they can lose, the posterior cuff and capsule, that kind of gets altered, that anatomy. So, it's kind of a patient specific, but I kind of go off of that. But
Okay.
I don't really do it that often. Yeah, I'd say it's pretty
Thank you.
rare. Yeah.
Thank you. Rob, any questions right now before we get into the rehab, docs, rehab, post
No,
orthopedics?
I think
No?
actually I'm pretty
Okay.
good. Yeah, thank you.
So you've done a posterior labral repair, maybe a capsular plication, and no bony augmentation. Do you Do you immobilize the patient? Yes or no? In what position and how long, Dr. Volpe?
So I would immobilize them, post-op, and I know some people they do different positions or different arm, positions. I mean, I think that's just unrealistic to kind of keep with compliance. So I would just, have them mobilized in a regular, sling, but we have a little bit more precautions with the posterior labrum, meaning you really want to avoid excessive adduction, internal rotation, flexion. So you really want to not put them in a sling and wrap them up, across their body. It's even like a little bit, you don't even want a body strap. You kind of want them to be sitting a little bit external. You want them to
Okay.
be, I'm kind of neutral. And then the phases of the therapy really limit getting into that, those danger positions. And so you kind of slowly build up all that internal rotation. But usually it's about a sling for like about a month, and they're doing, passive range of motion early on with those limitations, and then eventually getting in the strengthening phase.
Active range of motion around 6 weeks, 8 weeks. What do you around
Yeah.
there? Yeah.
Yeah,
That's
I
what.
would say you slowly, yeah. So like by 6 to 8 weeks, slowly progressing, just kind of week by week, getting a little bit more of that rotation.
We do some isometric strengthening early
Yeah.
on the rotator cuff in a neutral position at 0 degrees abduction because you don't violate any of the musculature when you do you do a deltoid mini split on that procedure? Usually you go to the deltoid pectoral groove or do you do a deltoid
Um,
takedown like in the old days?
no, I mean it's all no, I mean it's all
Oh, it's all
arthroscopic. So
arthroscopic now. Jeez, sorry.
arthroscopic. So you don't
Yeah.
have to, yeah, so there's no big muscle restriction. It's really, yeah, so it's all, yeah, so it's arthroscopic. But no, but I mean doing those, I mean isometrics, early on is very important. So
Wait, let's go back. Let's go back a step there. When you're putting that allograft in, you're telling me that's arthroscopic still? No, you have to make
oh
an
no, that
incision.
part. Yeah,
All right,
no, no,
all right.
no. Yeah, so that's right. Yeah, so a labral repair
Yes, that's
um
arthroscopic. I
is done
understand.
arthroscopic. To do the allograft, right? That's an open, yeah, that's an open procedure. That rehab is definitely, that rehab is definitely different because
Way different.
um
Right.
it's way different because, to get in to do it, you have to peel off a subscap. So you have to repair it. So you really have to protect
Mm-hmm.
that repair. And then the allograft has to heal. So you are a little bit more restricted with that kind of procedure.
Sure.
Whereas the labral repair, after that 6 weeks, you give it time to really solidify and you've got that passive range of motion, then you can start that active strengthening.
Let's talk about the practical aspect of this for all the listeners out there. If you send one of the therapists that we work with a patient that had a allograft, will you send
Hmm.
specific phases of rehab, or do you like the therapist to call to reach out to you via text or something like that, or how do you deal with that?
Yeah. So for my post-op patients, I always give a detailed PT protocol. Um, just to have everyone on the same page and that um there's no confusion with the patient too, because kind of they use as a reference, and kind of they start to hear from you guys at that point. So for post-op stuff, I always try to send a detailed protocol, but obviously you guys are the experienced therapists, so there's always some room for interpretation, or at least some some expansion on that, and always open to conversation. I mean, I'm in touch with, my therapist all the time, and, some are like, hey, like they're doing great. Can we advance them a little bit? I mean, that's awesome. Or sometimes like, ooh, they haven't really made it that much. I think we got to work on this more. That's fine too, So it's kind of, there is a set, try to stick with a protocol just to keep them on something, and give them some instructions. But obviously, you guys are like you guys are the experts at this, part. So I leave a lot of it up to you guys to advance, see how the patient's doing, work with them, that kind of thing. So I try to be specific, but I also follow you guys. You guys know way more about
Thank
the
you.
rehab aspect than I do.
Thank you. So the straight arthroscopic posterior labral repair and capsular plication. When would you expect that person, if it's an athlete, to go back to return to play?
Yeah, I mean, that type of that topic is also becoming something where I think people are trying to push a little bit more. I mean, I think the historical, by the book is around 6 months.
Yes.
For some high school athletes, that's like, I mean, like some of these labrum, these high school athletes with labrum, I mean, within a couple of months, it's like nothing happened, and they're so eager to get back. So, um, it's easier with the anterior because you can do the Sully brace. With the posterior, though, if you're sending them back out there to do what they did to cause this, it's a bit
Hmm.
tougher. You have to be more restrictive. So, between a 4 to 6 month range, depending on their sport, for something like weightlifters, linemen, more of a, traumatic force, then yeah, it's more in the 6 month range. If it's,
Right.
other sports, sometimes it's earlier. So it's case by case, but yeah, it can be up to 4 to 6 months to allow for full healing and full shoulder rehab.
Excellent. Can you tell our audience where to find you if they want to send you a patient, a posterior shoulder instability patient? Where do you see patients these days, and what days of the week? Do you have different offices?
Yeah,
Or all right, tell us.
definitely.
Thank you.
Yep. So I'm part of Optum, Optum Pro Health in New York and Long Island. So my main office is in Lake Success, New York, which is in Western Nassau. So it's right by New Hyde Park in Manhasset. I'm there Mondays, Tuesdays, and Thursdays in the office, and I'm there Wednesdays doing surgery in our surgery center, right in that same building. So we got surgery center, MRI, kind of everything in the same building there. On Fridays, we have a satellite office in Syosset, New York as well.
Okay, excellent. Thank you. Rob, any questions from the audience or last questions from you or Adonis if you're back? Anybody?
Oh, I don't see any in the chat. So what would you
Okay.
think is where was like what are the highest risk when they go back? Like, do you worry that therapists are pushed too much range too early, or do you have recurrences? Do you
Yeah,
worry about that? Of course you always
yeah,
worry about that, but
sure. Yeah, I mean, I think it would be, pushing the range of motion too soon. I would say pushing that kind of danger motions too soon. If they have them start, doing more flexion, internal rotation, adduction type things. If they have them, people are doing that on their own, not being so compliant, that could, and if it's too soon, that could stress the repair and even compromise it, and that would lead to recurrence. Um,
right.
if they're, go back to sport too soon and they do the same type of motion or have a, freak accident that, I mean, that could compromise it as well. Some things we can't control. I mean, this field's, they, athletes, they injure themselves doing a sport, we fix them, and then we send them back to doing the same exact thing. So these kind of things can always happen, you know, no matter what we do. But we do our best to restore these soft tissue musculoskeletal structures as best as back to normal. So, as
Yeah.
long as everyone's on the same page, following the protocols, avoiding any danger areas, and doing the full, rehab protocol and given time of recovery, then the outcome can, really be optimal.
So for these type of patients, not yours, what typical recurrence do you think? Why do people have recurrence besides? Do you think it's maybe the doc didn't do enough look at the bony, too much stuff, there's more bony extent than they missed, or is it just besides the
Yeah,
sport itself?
sometimes, yeah. I mean, sometimes it can be. I mean, there's definitely way more data about this kind of thing for anterior instability, where it gets into
Mm,
demographics, it gets into uh, the anatomical factors as far as bone loss, it gets into surgical technique, the number of anchors used, even sometimes. For posterior,
mm,
it's definitely not as well studied, and there's not that much data for it. But I mean, it's a combo of all those things. Maybe there wasn't enough, maybe, there wasn't any glenoid retroversion or something recognized. Maybe there was a little bit, maybe the capsule was, more lax than, usually picked
would
up,
have
and
thought.
that was an issue. So sometimes there's multiple factors that, that can lead to it. I mean, but if you stress, this tissue enough in the right way, then it can tear again. So, but it's usually a combo of things. Yeah.
Great. Thank you.
So Dr. Volpi, thank you for joining us tonight. I really appreciate your time.
Thank you so much for having me. This was such a blast and such an honor. So thank you for the invite.
Please.
I really appreciate it.
Thanks for coming.
Thanks. All right. Good night, everybody.